found that it is anything which can help or facilitate adjuvants. Remember that many of these interventions, as your younger brother, as a friend, to tell you what is right for the patients. Think about it, what I'm telling you. Just think, and then in vitro fertilization is what Mohan has written. I have referred to Americano is a black coffee. Americano you take to lose weight, and cappuccino and mocha you take to increase weight. If somebody says that both are expectations, can be a concern, may not be a concern. They want counseling and hand holding. They scratching, we do hysteroscopies, we instill lot of things. So let's see how we look at the scenario. People to increase implantation vasodilators like arginine, sildenafil, uterine relaxant, like it was a different technology, but ERA I deliberately skipped. Thank you so much. ERA is also an adjuvant. Who said ERA?
PRP.
Yeah, PRP, GCSF, scratching.
Stem cell therapy, sir.
𝐈𝐕𝐅 they are red. Actually, red means it's a red. Don't try red thing. Amber, you may try. Which cost money. So we have to see in case we do it, is it worthwhile doing it? Is it worthwhile using a magnet to sort out the sperms? Is it worthwhile patient who comes to us and to go in? We're keeping the session on for discussion now. And discussion can always be focused on red, amber and green. We're keeping the session on for discussion now, and discussion can always be focused on red, amber and green. It should not be focused on what I feel it should be done. Let's not go to that part. Let's talk about the red lights I've shown to you. I've also shown to you what is red today may become green or amber tomorrow. Keep it in mind. Thank you so much. We are all open for healthy discussion.
Thank you, sir. Thank you, sir, for the wonderful lecture.
Thank you, sir.
And a kind of eye-opener in such a topic. Like I was also so much enlightened with this red, amber and yellow. So I can see the chat box. One of the friend had requested to just elaborate more about the red color. So, and please interact, all of you, as is an open session. Just talk to each other and discuss about.
Thank you, Dr. Pankaj. Wonderful way of explaining. See, red, yellow, amber, and green. Very good.
You take on, ma'am. You take on. I'll have a break, have a glass of water. You be the coordinator now for next 5 minutes.
So, it was really wonderful. And the way you have easily explained, so palatable, so digestible, that you can easily now categorize which is red, which is amber, and which is green.
Great.
Definitely, it adds on to the cost. Definitely, it adds on to the cost, especially in this COVID era when people are hard of money. Then we have to think of this comes in the primary guidelines to economize the cycle for the people. We have to give these services, but how to economize, that is important. So we can just leave the red ones definitely, and the amber ones if they can pay, and we can go with the greens.
Thank you. So before we start discussion, I would like to invite our guest of honor, Dr. Mandira. What does she feel about in her enormous practice of more than 40 years? She have really seen the industry grow. You have seen our medical practice becoming from philanthropic and altruistic to commercial.
True.
It's become commercial. We are under the litigation. What do you feel about this, ma'am? With your wide experience, Dr. Geeta has summed it up very beautifully. Anyone can speak, but ma'am, you're the guest of honor. It's your privilege to just sum it up. Then we'll take the questions.
So
coming what you actually said, it's like very much commercialized. And what I feel is truly, I do not feel that much it has much of a role, except for certain things. Like in my practice, though I know like metformin has a, like evidence wise, there is not much of a there is always a debate going on for metformin. But in PCOS, I have definitely found a great amount of success in PCOS, and I do recommend metformin for PCOS. Though of course I know the evidence doesn't suggest that. I don't have any RCTs or trials like that. That is one thing which I found it good. The another thing which, like when I started my practice, like very early in like 1996, like that, I had one patient who was not conceiving. Like there was like 4 or 5 years like that, and she was trying her best and she was not conceiving. We were not very much into this IVF and all at that time, so just did some just routine exam, I mean all this complete blood pictures and all, and what I found it like she was having megaloblastic anemia. So just treated with just vitamin B12 and folate, and to my surprise she conceived within 6 months. So that was something which was like very amazing to me at that time. And I found like, and after that, I, of course, I do not recommend everybody to be taking that until and unless there is something. What I found the biggest thing, and what I also do in my practices, I tell them to take healthy diet. I tell them to practice some exercise, which I find it really improves on your ovarian reserves and all, if you can maintain a healthy life attitude. So I do also, I practice that also. I tell my patients that, except for that, and maybe a vitamin D, which I just commented, like if there is a deficiency, and what we find is like with Indian women, mostly they are deficient. So we can at least give at least 2K of vitamin D without doing any test. Or supposingly if the patient can afford, we can do a vitamin D test, and then depending upon that we can give them a 60K weekly once and all. But except for that, I am truly like mostly it doesn't work, or it works, it has to be like seen. But what the evidence suggests, what you have come out with such a brilliant lecture, and just comparing it with the traffic lights and all, so it was really great to know all that. And I do feel that most of the things, yes, needs to be researched and seen, as you have very rightly pointed out. What is today right may be wrong tomorrow, and what is today's wrong, it may be right tomorrow. Today's right may be wrong tomorrow. So I feel that in my I am a old school thought, so maybe I am that, but mostly I wouldn't prefer to give out of the way anything like an adding up to their cost. So that is how I practice. I don't know.
Thank you, Dr. Mandira. Anybody else?
I totally agree with what Mandira has said. Definitely. And there's, commercialized and industry driven, so much pharma driven, and so much competition driven. See, if somebody has conceived, you have not given that medicines, definitely your colleague has. So you are not a good doctor. See, that's the thing.
Actually, we get patients asking us to give us, no, you give some vitamins, you give something, you give some, yes, so that it will make my eggs quality good. Yeah. And not only that, like I get like many people from Somalia, like international patients, and they will be going from pillar to post. They are, I think they are much more getting into the market, going from one specialist to another, and they would be coming and pestering, no, you give some medicine so that my egg quality becomes good, because I have had a failed IVF once times or 2 times. So that is what we are getting. We are getting under the pressure of the patients too, not only the commercials, but under the pressure of the patients too. So it is our duty to tell them like what is right and what is wrong, and just to convince them. And of course, if we do a good counseling, that helps a lot.
Perfect. Thank you so much, Dr. Mandira. So I think, Pooja, all yours.
Thank you, sir. So, sir, there's few questions if you allow me to open the chat box.
We'll take.
Yeah. So there's a common query, around 8-9 queries about how to use the DHEA and its doses and indication.
DHEA, as I told you, is still amber. Still amber, but I do use DHEA myself. Amber, I've told you, when we have an amber, sometimes, when you cross the red light, it's getting orange, it's cross. The policeman catches you, you tell him, I didn't see it. I was behind a car, or probably in case I would have suddenly stopped, someone would have banged behind me. So I was trying to actually help people behind me. So you say anything, and the traffic policeman will probably check your challan. Okay, it was orange. Amber, he may let you go. I also do such malpractice many times. I use a lot of amber drugs. So DHEA is an amber drug for me. I normally cross the red light here, zebra crossing without stopping, and blame it on the wrong timing of the orange light, not mine. I didn't read the time. When I was in Israel 16 years back to learn IVF, I'd gone to a place called Technion. That's an amazing place. In case we have not 10 pages here present, or people present here, you'll find that they'll have 10-15 Nobel laureates among them, in case they have a meeting there. I had an honor of working with them for something, learning from them. I'm very, very small. They're all gods. In that city, I learned a very nice thing. The roads are empty. Talking 15 years back. The roads were all empty. And they had an option. That when somebody was crossing the road, they had an option to change the color of the light. It still exists in Europe at many cities. You can go and make it red and cross over. I wondered in Israel, which is such an open country, and then nobody could be seen for miles. When they used to cross the road, they used to make it red and cross the road. They had an option to change the light colors. So that we should not do. That's what I say, that in our practice, that we should not do. Don't change the color of the lights. But amber, you may play. So DHEA, I'm playing with that. We give DHEA is available as a 25 milligram tablet or a 75 milligram tablet, as a slow release tablet. Some people have added melatonin to it. Some people have added multiple drugs to it. So DHEA 75 milligram per day, I give for around 3 months before we start the treatment. 75 milligram per day for minimum 3 months before I start the treatment. This is what I'm doing. I think melatonin I'm not adding, but DHEA SR I'm using. This is what I do. Single of the day.
Do we combine it with OCP?
Combined with?
OCP, sir.
It doesn't make any difference. You can combine it with anybody, anything depending upon the indication. But 3 months DHEA you have to give. OCPs are a different.
What about the ecosprin?
Again, I have told you, ecosprin, they're all, I've shown you, they're all ambers. They're not greens.
Because we are giving ecosprin to each and every patient.
That's what I'm trying to tell you today. I've shown you some lights, amber lights, and I'm going to send you the articles also. After this, as before, all CRs will get a bunch of articles right away.
So do you give DHEAs to all women or only to the ones who have a borderline ovarian reserve?
Normally, all to Haini should be more than 37, 38 years of age. Okay. And the ones who are having AMH less than 1, or say even 1.5, 38 years, less than 1.5, I do give. But I don't give as a routine. But my practice is such that I only get people more than 35, 36. I don't get young. Average age at my clinic is 38 years.
So after 3 months, does it make any difference?
No, I've not found any amazing thing, but it's an amber. I'm giving at least, I'm doing something. I feel I'm doing something, and it does make a difference. But our practice is not that way that we have carried out any RCTs. Because you ask me, does it make a difference? I really can't comment because we don't have any egg-to-egg embryology-based clinical pregnancy outcomes. I don't have the data with me, but we do give. So, as a clinician,
in your experience,
what about the dose?
You might not be having an RCTs, but in your experience,
I'm happy, ma'am.
I'm happy. See,
constantly maintaining pregnancy rate of 60% in the woman, even more than 36, 37 years of age, I feel it is working. But here I'll tell Dr. Mandira one thing very clearly, that medical science has come to a point where everyone is doing specialized work. There are people who are doing RCTs only. There are people who are doing a lot of research only. Some people are carrying out trials. As a doctor who are running a very busy clinic, you just can't go into these meta-analysis. हम लोग नहीं कर पाते. I've written 9 books. I've written large number of publications. I've done enough. But finally, I have stopped this because I'm not able to follow this. Because in case you see an OPD, you work for 13 hours a day in the OPD with the patients in the OT and lab and doing embryology also, then you can't start comparing the data. So data comparison is being done by a lot of societies like HFEA, BFS, there are Cochrane reviews which are there. They are comparing the data. So I just follow that. This is what I've learned. There's an easier way to follow the people who are more educated than me in terms of carrying out research. So as for research, DHEA is an amber zone. It's an amber zone and it can be used, and I'm using it. Pregnancy rate is not fallen down in 38 plus. This means that it is working. This is what I feel.
Sir, what about the RG prime? Routine use of RG prime.
RG prime I use when there's an ultrasound has been done for the patient and RA, PIs are high for that patient. The blood supply, the blood supply to the zone 3 is or zone 2 is not there, then I put the patient on RG prime. Not everyone, but whenever I have in a pre-workup, I find such ultrasound, I add RG prime.
And what about sildenafil, sir?
Sildenafil I give when the cycle has started and the endometrium is not growing. I add sildenafil also. 50 milligram daily dose I'm giving to the people.
So
DHEA
in young patients with poor ovarian reserves.
Yeah, DHEA we are giving.
Very young patients with poor reserves. Will it help?
See, there is no data per se in which group it will work better. But anyone who has got less number of X who has got low AMH, we are using DHEA. We are using it as a blanket treatment. I don't have any experience in saying that in which subset is going to work better. I don't have that data. And the data is not present anywhere as such. But any woman who's a poor responder, who's going to have less number of X retrievable, or who has got low AMH, low AFC, we are using DHEA as a blanket. We're all giving. It's an amber zone, and it should be
one more
after confirming the patient. Yes.
One more doubt. With DHEA, some patients like they have to travel and something else, so they ask us to induce the same cycle along with DHEA for at least for IUI. Can we do that?
Yeah, you can do that, but DHEA will take 3 months to develop all those receptors, change the androgenic milieu. It will take 3 months for it to act. If you do it before that, I'm not very sure how much DHEA benefit will be given. A lot of Japanese paper came a few years back, and Koreans, which they said that it works better after 3 years of administration. This is what we always follow. Even in an amber zone, 3-month DHEA should be given to that patient. So cut off 3 months.
Yes, so once I remember, in case DHEA is given and they conceive, the effect of DHEA over the embryo, in case they conceive.
This is actually, I'm again saying that it's an amber zone. There are no studies over that which can actually give you a call. Few scattered papers here and there. There are no randomized controlled trials over there that is going to do any magic. Every second paper is having pros and cons, but DHEA in simple terms, in case you give, as per the RCTs, it should be given for 3 months before the patient starts, before you start the patient's treatment. And then patient will have better outcome. I'm not aware of any case where they say maybe I've not read enough that giving DHEA patient conceives and baby can have a problem. I'm not aware of any paper like that till now.
Okay, sir. Thank you, sir.
If it is there, you please tell us.
Gone through many IVF cycles. What are the indications of use of prednisolone after embryo transfer in your patients?
Ma'am, we don't give at all, but When the patient has got multiple failures, she has got 2 or 3 IVF, we get multiple failures before. When they come to us, then we add heparin also, and then we add prednisolone also, but not as a fresh cycle. In case we carry out an IVF for a patient, 1 failure or 2 failures, I don't give anything. But in case there are more than 2 failures, the 3rd cycle we are doing, either we are doing or somebody else is done. 3rd cycle onwards is my way of working. I add prednisolone also and heparin also. But this is what I do, but they are in red zone. As I've told you before, we must know what is right. We should know what is our benchmark and competency and what we can do to improve our practice. So I don't give prednisolone and heparin to patients. I don't like it. But yes, in case she's already had 2 failures for 3rd time, when I don't know the reason, I do add.
When do you?
The role of steroids in PCO patients for stimulation?
No role, no role. No role at all. There is no indication of giving steroids to patients.
When do you add the steroids? When do you add steroids in that patients in which you have had a failure?
In IVF, madam, we add steroids after the day we have done the embryo transfer. That's the day we add steroids. Ma'am, in case I add.
Heparin also at that time?
Yeah, same. That I do, but here minded is after 2 failures. When we have 2 failures, I add. Otherwise, I don't add.
The role of PRP. The role of PRP in OAMH patient.
The dose, first of all, somebody said dosage. Dosage of heparin is 1 unit per kilogram body weight. That's the standard dose of heparin we give to people. Standard dose of heparin. We give standard doses of all the drugs. And Sumi, what were you saying?
The role of PRP in low AMH patient.
PRP, again, it is actually in amber zone, but PRP, we have never found any big benefit in PRP. PRP, I will say that don't do PRP.
Okay.
In case you talk to any European or a US person, they'll ask you, what is PRP? GCSF and PRP gradually they are going off now. There is no.
What about, sorry, intralipids, sir?
No, big no, red.
Any role of steroids in NK cell positive cases?
Red. I'll be sending you all the documents in some time. We'll send you all the documents. And before I forget,
Rama ma'am wanted to say something.
One thing, Rama ma'am, one sec. All the people who come to us who are not in our groups, who join directly from a link, they must send us a WhatsApp message so that we can put them in the group and send you the articles. Otherwise, you won't get them. Because you join directly. That's the point. Yes, Rama ma'am.
Sir, yeah, I want to say one thing, that one can go in for till the whole of life. I have seen one should go for diagnosing the cause of infertility till the level it is possible. First thing. And if you are not able to reach that level, whatever is available, you should treat. If no cause found, if cause is found, treatment of the cause. But if no cause is found, and according to the available investigations, it is a case of unexplained infertility, then one should go in for non-invasive investigations as far as possible, and cheap treatments as far as possible. Of course, with the good counseling of the couple.
Correct.
Good counseling and giving them examples of the people who have conceived with this much treatment only. And make them meet them, so that they are encouraged by those people that it can happen. The thing in our society about these RCTs or otherwise, what I am seeing, I worked in a private institute for about an year. There I saw these research that is going on. People are not doing proper treatments and they are putting that as a research. When the research is not honest, then there is no value of that research. I saw one student of the most #1 infertility specialist, IVF specialist of India from Bombay, who is practicing, and he is doing to IVF to all the people who are coming to him somehow or the other. And the baby carrying rate or pregnancy rate is very low, And if it is there, he is doing IVF again and again and putting them as RCTs. I am very much hurt by that fact. He is putting those RCTs. And what are the use of those RCTs? I don't believe people should work honestly. That is the first thing for the doctors, which is not occurring, especially in our country. I don't know in other countries. In our country, this is a lot. I don't know. And everyone should look inside himself to see this fact. And one should have faith in God or in some random superpower so that they don't do dishonest work. That is the first thing. And this whole thing is being commercialized by the market forces, by the doctors, by the IVF specialists, which should not be done. Without that, there cannot be a true evidence generated by the research.
Correct. I fully agree with you, ma'am. That's what I'm saying.
And I am very much listening to your lectures since the day I have started. I love those lectures and I love your honesty. That is a fact. That is why you are so nice in your treatment. And I will like to send my patient if needed to you only and you only.
The thing is that we should always keep our hands on our heart and talk. That's it. हम कुछ गलत काम भी करते हैं. As I've told you many times, I also cross the red light, amber light. We all cross, but we should know that we are doing a wrong thing. That's the main thing. And
yes, we should enter the red light only if the patient says how many amount of money you go on. How much money? Money is no problem,
Correct.
problem. Only
Correct.
then if indicated and you are available.
Correct.
Then go on increasing that.
Correct.
Then go on entering into the red zone.
May I take?
So I do add adjuvants which are in red, in amber, but tell the patient that is spending money which doesn't have much of benefit. Like a lot of people come to me, they want to have growth hormone. I say no, I want to growth hormone. I don't add. They go to somebody else. Let them go. I feel growth hormone doesn't work much as per the evidence. And all of you must read. You must keep upgrading yourself. In case you won't read, then you'll go by. उसने ये पढ़ाया conference के अंदर, उसने conference में पढ़ा दिया, उसने study कर दिया. We start following people. Don't go by single papers. Follow the RCTs. If you really want to learn, go to British Fertility Society, HFEA, ASRM, and HRA. So all these Cochrane's, the aim of our CSRs are that moment it is over, within half an hour, 15 minutes, you'll get all those articles which are pertaining to adjuvants. Read them, take your own call.
So the person that is doing IVF, it is not for one person. It may be for many person like him who are trained like that. He's an IVF specialist in the region, known IVF specialist. But what is he doing? He is doing this. Even you cannot see the seminology report. You cannot ask. The seminology report is not there with the patient, neither with the people working under him. He is only hiding the data. He's the only one who is hiding the data and printing the papers. Just see, people are, and many people are doing like that, sir. Sir, how can this be stopped? I don't know. Especially people are going in for IVF. New postgraduates, they are entering into IVF because this gives them a lot of money. They don't have any other interest in the OBGY or oncology or something like that.
Great, sad thing.
IVF is such a field where commercialization, I think, is the maximum.
I think it'll change.
Ma'am,
Yes,
we have people like you, and I'm sure you all will enlighten those coming with such thinking of in mind. So
I was hesitant to talk in this August gathering to talk such things.
Thank you. Thank you so much. Meenu is a young budding, she's at crossroads in her life. And she is very well shipping into a ART. Meenu, what do you feel about the thing?
Sir, absolutely, I do agree that minimum agents as add-ons should be used. So I want to ask you a clinical scenario I recently faced. So this patient, when we did a pickup, the endometrium was fine. Even previously, whenever I stimulated her, there was never a problem with the endometrium. Now, when we went for a frozen transfer for her, we gave all the amber agents you just mentioned. We gave her estrobate, gave her sildenafil, because by day 13 also, her endometrium was only 6.7. So then went on to give PRP and also GCSF, barely touched 7 by day 15. And eventually 2 very good blastocysts that we transferred, but she gave a UPT negative. So sir, subsequently kya karenge?
Nothing. You should look at her hormonal profile. How much is her LH? Number one, I like to ask you, in case you know that. And how much was her endometrial blood flow? See,
the endometrial blood flow was okay, though where I do it, they don't really have a very good Doppler flow showing, but she did check, because I obviously don't do it all on my own. I do it at a center. So we did check the flow and she said it's good enough.
No, to know one thing, we should always look at RI and PI of the uterine arteries. That's very important. Endometrial resistivity is very important. What we see is not always correct. See, zoning of the blood flow is, see, a woman is not like a machine. Even if you use your phone, you will find both men and women are not like machines. When you use your phone, you'll find that even an iPhone will get hung up sometime. Your application won't load. Same thing happens with a woman's physiology. This poor girl whom you are talking about, not poor, I mean, it happens, we're all poor once in a lifetime, we all have issues. What happens in their life is that in that cycle, probably the receptivity is very high, the endometrial resistivity is high, and the blood supply to the endometrium is less. It won't happen in every cycle, but probably it is happening in that cycle in that patient. So you have seen, just to give you a different preview, I have had women who are beautiful to go with, endometrium looking sparkling, blood flow sparkling after 4 to 5 months of our working endometrium. And then I order for a P4. I order for a P4 and P4 is 13.
So when do you order for a P4, sir?
I don't normally order for P4, but nowadays I started ordering for P4 in all the women who have got endometriosis. I'm finding that I've had 3 bad cases in past and in 2 months. When anyone has got endometriosis, always order for P4. They are LH hypersecretors. The P4.
So the LH that you asked me is a 9.32. I've kept her papers with me.
So yeah, correct. So LH is on the higher side, no? LH is on the higher side.
Yes.
And when LH is on the higher side, she's LH hypersecretor. So LH can really create havoc in the woman at many point of time, because it will bring P4, it will cause relaxation. These are multiple things happening. So first of all, I want to tell you that one cycle, first of all, when you do an embryo transfer or a blood supply has to be done by a very qualified person. Nowadays, initially we were very happy with 30-40%, but now we are touching 60% or 70%. So until endometrial receptivity is not good, we don't carry out any embryo transfer. So in your patient, I will say that I never jump to PRP and GCSFs. I've done enough of these things. Enough of these things. I don't do that. Don't do it anymore. In the army, we had a lot of avenues. We have large number of patients. So any technology came, I just took it on. I said do 200-300 cases back to back, and then I realized it didn't work for me. And no magic it did on ultrasound. So I stopped doing it. But I think you should take it quietly. Let this cycle go. Next cycle, in case of blood supply, you have to check properly. This is important. And such patients, they work with arginine very well. Arginine is
arginine also, that we started right at the outset.
Arginine works very well. 𝐂𝐲𝐸s can be given to such women. 𝐂𝐲𝐸s are very good. And just my favorite is Ayurvedic medicines. They work very nice for me. I give a lot of Ayurvedic medicines.
And sir, would you suggest that we do a hysteroscopy before doing the next transfer?
Never. There's no role of hysteroscopy. Hysteroscopy का role ही नहीं है. Hysteroscopy का role ही कोई नहीं है.
ठीक है.
3D है ना आपके पास में. You have 3D color Doppler now. Why do you want to see? The only issue is that we want people to spend money. 50,000 for an hysteroscopy. Then Mino will say, I want to scratch it also. So she'll make a bill of hysteroscopy and
Exactly. That adds on so much. I'm already worried about that. As to
poor girl, you can spend rupees 5,000 and do a 3D color Doppler, will give you same evidence. So make a treatment cheaper. But should know logically देखना क्या ultrasound के अंदर.
Was a big question mark for me.
RIPI indices, uterine artery, arcuate bundle, how does it look like? How are the arcuate, radial, basilar arteries? Zoning kitna ja raha hai, is going to, your basilar arteries are going till zone 3 or not. This has to be checked. But normally we say, we've done a color Doppler done. Who is on the color Doppler? Who doesn't know what they are doing? Next time, you do one thing. You start putting color on a vessel, on endometrium. You increase the color intensity. You will see every patient, you will make it that you will have zone 3 vascularity. It's not simple to do. Adjustments have to be done, windows have to be created, then you do color Doppler. That's very important. So I feel that it should be done by somebody who's qualified in such cases. Don't lose heart. Such people, they respond very well. In case you really want to give them something like ashwagandha and ashoka rest. They work very well for me. I give many of the drugs like Fulgrid and other things, but I won't discuss them here.
So maybe about like a month or two prior to the next transfer.
Yeah, pre-treatment. That's a pre-treatment. Ashwagandha and ashoka rest are very good drugs. In case you have refractory endometrium, Fulgrid works for me. I give it. So they are all nutraceuticals. There are no green, red, and other zones for that. But I use a lot of Ayurvedic medicines. Yeah.
So I have a very question from Dr. Rabia Arshad ma'am. Please keep on asking the question of, is there any role of tamoxifen in improving the endometrial thickness? And one more question, role of prednisolone after embryo transfer.
Rabia, can you put in your camera and ask the question yourself? We have not met Rabia. Rabia, say mile hum. Rabia, can put in your camera, say hi to all.
Hello, sir.
Hello, Rabia. How are you? You're from where?
I'm from Pakistan.
Okay, Rabia. Tell us. Yes, Rabia. Hi. Correct.
Hello.
Rabia, prednisolone I don't give. I don't have any experience of prednisolone. I give dexamethasone, 0.5 milligram per day. I give to the patients after embryo transfer.
For how many days?
Prednisolone, we start from the day of embryo transfer and we continue till the day her beta CG comes positive. Then I stop.
Okay, thank you, sir.
But that's what I do. It's not indicated. Again, it is not indicated. It is red color. I give it is a different issue, but it is red.
Sir, is there any role of tamoxifen in increasing the thickness of endometrium?
Tamoxifen is a very good drug. Tamoxifen you can give in the usual dose. Whenever the patient is not responding to clomiphene. Clomiphene, we know clomiphene doesn't allow the endometrium to build up well. Letrozole is better. But whenever we have refractory endometriums, tamoxifen works very well. Yes, you can give tamoxifen. You can give. See. Do you give tamoxifen?
No, sir. I just read the article and just asking.
Yeah, you can give. Tamoxifen.
Sir, I want to ask, in a patient of frozen embryo transfer, if we are starting, if we are started to prepare endometrium for FET, then should we give any letrozole or type of thing to just start?
No.
Just improve the endogenous estrogen levels?
No. Why is it required? You've got beautiful estrogens with you nowadays. Why do you want to give letrozole? Don't mess it up. See what happens when you give letrozole, follicle comes up. And when follicle comes up, LH comes up. When LH comes up, P4 will come up. See, every follicle which you are creating, that follicle is creating for you progesterone also, no?
Yes, sir.
So that's not good. Many natural cycle, when you want to give a transfer, then people give letrozole. It's a natural cycle transfer then. Then you don't give estrogens. Then you only give letrozole and make a follicle. When the woman ovulates, then you do the embryo transfer. But I don't do that type of practice at all, so I can't throw much of light on that. But you can't combine letrozole and estrogens. You can't do that.
Yes, sir. If we are going for natural transfer, then we can give letrozole.
Then you can give.
If we are planning for FET, then it is not required.
No. For natural cycle, many people give Many people, non-natural cycle, combined cycle, people give letrozole, clomiphene, HMG also people combine. They combine tamoxifen and HMG. So that's a different ball game altogether. But for a plain simple frozen embryo transfer, see that there is no follicle at all. There is no endometriosis at all. In case you have a follicle, that follicle will grow, start getting LH, and then LH will get progesterones, and then your P4 on the day of embryo transfer. The P4 on the day of starting progesterones will touch 5 or 6. The cutoff is 1.3. There the problem comes.
Okay. So there's few questions about a few common topic. I just want your inputs on that. So questions are kind of indication for the growth hormone and when to start, indication and dosage about the arginine sachet, vitamin E, so all these things. So I
just, growth hormone is in red zone, not to be used. But many people demand growth hormones. I don't use growth hormone anymore. I've stopped it until somebody very much exists. Rabia wanted to know the dose of dexamethasone, 0.5 milligram dexamethasone, Rabia. So growth hormone is 4 IUs per day, starting from the day of stimulation. From day 1, you start giving growth hormone and give it till the time the day of trigger. Till the day of trigger, we are giving growth hormone to the people. So 4 units per day for 10 to 12 days we are giving. Indications are elderly women, poor ovarian response, poor responders, it's known to work there, but I don't use it anymore because it's an expensive drug, so I don't use it. Until it's really demanded by somebody, I don't give it.
Vitamin and indication for vitamin E and arginine sachet?
Arginine sachet we give in case a woman has got refractory endometrium. We have poor zones of vascularity, then arginine can be given. In case resistivity index of your uterine arteries is higher, it can be given. So arginine, exactly I don't know how many milligram a sachet is. They come as a sachet only. I'll have to read and let you know. So we can give them 1 sachet per day. And arginine you can keep giving as much as they want to give. Arginine is a
5 gram sachet, sir.
5 gram sachet, yes. Thank you so much, Sushma. Thank you so much. So arginine is a 5 gram sachet and you give it every day. Some people give it twice a day. And it's a safe drug. It's an uterus ventricle, won't cause any problem. But arginine do cause vomiting in some people. So that you have to just cater for it. It's a safe drug.
The duration of sildenafil.
You can please put on your cameras, Ananya. I mean, in case you want to watch, just put on your cameras.
Duration of sildenafil. Okay.
Sildenafil. Sildenafil is again a red tablet. It's a blue tablet, but sildenafil is a red light. We don't use sildenafil for all. But again, when the patient's blood supply is poor, endometrium is not growing well, we do have sildenafil 50 milligrams per day vaginally. We do add. But sildenafil is a problem in IUI cycles. Don't add there. In case you add sildenafil, sildenafil is toxic for the sperms. So in IUIs, we advise people to have natural intercourse. In IVF, you don't. It's safer in IVF, but in IUI, just be careful that once you do add sildenafil, then the natural milieu of vagina is not congenial for intercourse because all the sperms will die. So then you can do 1 IUI and that's it. Or do 2 IUIs in case required. But natural intercourse won't work in that case.
Right.
Sir, do you prefer... Sir,
sorry, ma'am. Yes, please, ma'am.
Sir, what you prefer, the oral sildenafil or vaginal one?
Always sildenafil is vaginal only. Vaginal only. Oral dete hi nahi hai.
Okay, sir.
Oral sildenafil, no oral, she'll faint.
Okay.
Half of the men are fainting after sildenafil.
Okay.
Sildenafil should be given vaginally only so that it doesn't go to her brain and cause hypotension and colored vision and anxiety. Palpitations, sildenafil has got many complications. So
yes, sir.
Should not give it to the woman. Oral, only vaginal.
Can you use low dose aspirin?
You can use, I'm also using it. But it is, I told you, is amber to red. Evidence is not in favor of giving aspirin. And I send you I'll be
If the
sending you.
patient has previous miscarriage, it does work.
Yeah, it's a different thing. Again. It's a different issue we are coming to. Recurrent miscarriages ke andar, it can be empirical. So it's an empirical therapy, no? So there you use anything. In empirical therapy, as I told you, when a patient has got 2 recurrent miscarriages and she's come to the 3rd pregnancy, I will add sildenafil, 75 milligram BD, I'll have heparin, I'll add anything. But that is empirical. In case apply is negative. When apply is positive, then it is therapeutic. Then she has to take. But in case, I assume in today's world, when a patient comes to you after 2 miscarriages, by that time, everything has been done for her. No, I'm sure her apply has been done, karyotyping has been done, hysteroscopy has been attempted, 3D color Doppler has been done. Then whatever we are adding is empirical. You can add, but you say it is an empirical therapy and underline in red. It's empirical therapy, not therapeutic therapy. Dr. Panchdev is raising his hands. Yes.
Yes, sir, I want to just ask one question, and this question is from Dr. Jaya Rai. And sorry, Dr. Panchdev Gupta, just give me 1 minute. Let me just read this question. And thank you, sir. And after this, I would like to request also Dr. Jaya Rai to please come on the camera. And the question is how to reduce LH levels in patient of PCOD not responding to lectures
very tricky question.
And high day to LH.
Very tricky question.
So, Dr. Jairai, please come on the camera and let's discuss about it.
Hi, I really appreciate it.
Yeah,
hi,
sir.
Hi, Jaya.
Good morning, sir. Yeah.
Lovely question.
So basically that was my point, because I have few patients of PCOD who have, in spite of giving OCPs in previous cycle, when we stimulated with letrose, they did not respond. And then the next cycle, when I did her LH level, it was almost twice that of FSH. So basically.
So this is a very good question. Very, very good question. I mean, it's always a very tricky question for all of us. But remember, Jaya, that there is no role of doing LH in PCO. First of all, there is no role of doing LH.
Yes, sir. So basically, patient did not respond after giving letrose. That is why I did her LH in next cycle. In spite of giving 5 mg letrose, she did not respond. Initially, so I didn't do her LH because it was known that she was a known case of PCO, so her LH must be raised. But when she did not respond in the next cycle, I got her this thing done.
LH. Agreed. Agreed. Very, very nice question. In fact, we're going to talk about LH curves. So you can speak for hours. And I think in case you were there in the previous CRs, we have spoken about LH. In our batches, LH is my favorite subject. Trigger and LH plays havoc in our lives all the time. Just remember that LH in PCOs, what happens is that PCOs have got, they are LH hypersecretors, and they have got on day 2 itself, they have got raised E2 and raised LH. You really can't do much about them. So to treat them, there are 2 ways. You always start this cycle after some amount of downregulation. And how do I downregulate them in the pre-treatment? I give them metformin. Metformin is not indicated, but I give metformin on the pretext that will reduce her ovarian hyperstimulation and also act as an anti-androgenic agent. I give them metformin for minimum 2 months. I give them Dine tablet. Dine has got
cyproterone
acetate, CA. It's got CA. So cyproterone acetate will reduce the androgenic effects in her body. So I give androgens, I give cyproterone acetate, and I give metformin for 2 months. Start their cycle. And remember that PCOs can have clomiphene resistance. They can have letrozole resistance. So letrozole resistance, हमने कहाँ तक बढ़ना है? Like clomiphene के साथ क्या problem था? That clomiphene will initially be starting with 50, 100, 150, 200, 250. Then finally we settled at 100 milligram clomiphene. Letrozole के अंदर we can play with the dosages. We can give them 2.5 milligram as the approved dose. But people tweak and they give 5 milligram. Then they can give 5 milligram for 5 days. They can give 5 milligram for 10 days. They can give 2.5 milligram for 3 days, 5 milligram for 3 days. Then they can give 7.5 milligram for 10 days. There are multiple regimes of letrozole are available. So you can try those regimes, and letrozole resistance can be skipped very easily. It can be skipped. But in case you are unable to do it, I think then letrozole, people after giving Dine and metformin, failed letrozole, add gonadotropins. They work very well. Start with, depends upon the AMH. Now, when the LH is high, how much is the AMH? I like to ask you. Did you do the AMH for this patient?
Sir, AMH was, no, sir. In this patient, I did not do her AMH. She's a young patient, around 23, 24 years old, and I did not do her.
So, Jia, just remember that LH doesn't have much of a role. In case you do for one, just I keep harping, and my family, my extended family, when the classes, they keep fighting with me every day. Okay, sir, why do you want us not to do these many tests? I say keep it cheaper. The 2 tests are required, AMH and antral follicular count. Okay. So what is required, Jaya, here is that you should do their AMH. Okay. AMH will tell you what is their actual status, not LH. LH is a very LH is a very funny hormone.
Yes, sir.
I will just give you one example. I don't know how much time I have. I have 10 minutes. And a woman having, when you look at her FSH values will go from 3 to 4 to 7, 8.
Yes.
We can go from 1 to 21 or 1 to 25, 1 to 10 it goes P4 to on day 21. Estrogens, they go from less than 25, they can go till around 300. But in hormones, the most beautiful part is LH. LH is one hormone which comes, is like a pirate. You know what a pirate is? Pirate comes in the midnight, so takes over your ship, and then he walks off. Throws you in the water, throws anybody in the water, and he takes your ship off. He'll come in the midnight at 1 o'clock. Half an hour, pirate will take your ship. LH is like a pirate on the seas. It'll come, LH is just going around, Thakawasa, 23, 23, 23. Suddenly it'll go up, and the value will go to 200. It'll go up within 12 hours, touch 200. Correct? The havoc, total havoc, and come down in 20 hours. In 30 hours, LH has gone from 3 to 4 to 20 times its value. It may touch 200. So LH is a very fictitious hormone, and really can't trust LH in the mid cycle. I mean, don't trust LH from day 2 to day 8 or day 9. But to cause and trigger, that time LH monitoring may be important, but not. That's the reason we do LH surge and the UPT test for urine test for LH or serum test for LH. So in a case of PCO, always look at AMH, because how will AMH support you? You've given letrozole to a patient for 5 days. She's not responding. Yes. So take 5 milligram next cycle, not responding. In case you have courage, give 5 milligram for 10 days. If you don't have courage, after 5 days, you add gonadotropins. Okay. Gonadotropins will be titrated along with your AMH. Yes. That's not with your LH.
Okay.
That's in simple terms I can tell you due to paucity of time, but do AMH. That's important.
Okay. Yes. Okay. Thank you, sir.
Thank you. Welcome, Jen.
So many requests for the list of red zone and
they'll be sent to them, Pooja. They'll be sent to them. There's an article. I'll do that. All the links in the WhatsApp will come. Panchdev, question le lete hain. Sir is waiting.
Yes, Dr. Panchdev. Extremely sorry, sir, for waiting.
Where are you driving early in the morning?
No, I went for a cycle pickup.
Wow, great.
Hello, sir. Hello.
Hi.
Hello.
Hi.
Yes, sir.
Hello.
You are
sir.
audible.
Sir, my question is
you are audible.
Hey, I'm audible?
Yes.
Sir, my question is a very honest acceptance of taking Ayurvedic and prescribing Ayurvedic medicines. I oblige that because most of the consultants, they don't accept it on record. They give Ayurvedic medicines, but it's work wonderful. I really have a very good experience.
Great.
And my question is, sir, what is your take for a down regulation protocol for FET? Whether you use a depot, whether you use a agonist like a daily injections. I just want to take your take on this.
Yeah, the take is pretty complicated one because it depends upon why we don't down regulate for FET at all. First of all, FET down regulation should not be there at all. There is no concept of FET down regulation. That's a take home message. Clearly, don't down regulate. Number one. Where do you down regulate? There are two places you down regulate. And these two places are when the patient has got endometriosis or somebody has got PCOS. Two places we down regulate. And why do we do it? In endometriosis, I have a couple of cancellations because in endometriosis, I don't know from where does LH comes, but LH comes and the P4 goes very high. So all my bad endometriosis cases, I'm doing P4 now, and I very frequently find that on the day of starting the estrogens, their P4 is high. P4 is touching 8, 9, 10. And I have documented these things a couple of times. So now what I've realized is that I've learned to start down regulation in endometriosis cases. Start down regulation from day 21. Dr. Gupta, day 21, day 2, I give them a depot. I give them a depot of Zolodex or whatever we want to give. And from day 21, I start down regulation with agonist, Leupride or decapeptyl. And then continue in that small dose till the day of embryo transfer. Not day of embryo transfer. Yeah, it's the day we start progesterones, I do that. But this is the protocol for the people who have got endometriosis, because then I'm actually scared. I don't know from where do they get LH and P4 goes high. I'm myself shocked. I don't have any answer. And for PCOS, I prefer to down regulate in case required. In case they have very basal, very raised LH values, I always down regulate from day 21 with Leupride or decapeptyl. But here I don't give depot. Endometriosis.
Daily injections.
Daily injections. But for endometriosis, give a depot and daily injections.
Acha, for endometriosis, they are depot.
Depot and daily injections, and for PCOS, only daily injections.
Okay. Because to get rid of LH, premature LH, which is very much complicated. This theory, what you just said, it's like a pirate. Even starting with the estrogen also, estradiol tablet for FET cycles, we may get this LH culprit in this, and we have to cancel in mid of this. How to deal with this?
You will get it. You just can't help it. People come and I can see that yellow panja, yellow hand. There's like a slap it. People come and give on my face. I've been slapped thrice in around 2 months. Thrice people have slapped me for this because I was following green all the time. What is the role of doing these things? I honestly, why should I do it? Like a big man, when people hit me on my face, I realize, okay, I should doing it. Now I've learned. Endometriosis, LH surge comes from where I don't have any answer. In case someone can tell me, I'll understand well. LH surge will become P4. So whenever you're doing an FET for an endometriosis patient, always carry out their P4 before starting their progesterones. You'll find P4 is high. It will always occur with the VIPs. I've had people whom I've said, today you start, and after 2-3 months of workup, you're ready to go, and in the evening, P4 comes to 9, 15. So the take-home message is, we'll talk in classes. This is Dr. Gupta. ये हमें class में हम teacher 5 घंटे बात करेंगे इस issue को लेकर time आने पर. But for the common people who are there, who are not part of our gang, our internal gang, just remember that we should give for endometriosis depot and shot, and for PCOS only shot in case indicated, not for all also.
Thank you, sir. Thank you.
Okay, okay, sir. We'll talk about these things. We'll get sick of, start from the menstrual physiology. 6 hours we'll talk on this issue, minimum.
Thank you, sir. Thank you.
Okay. Hi, Deepak. We can't hear you, Deepak.
Good morning, sir. Deepak, can you hear me?
Yeah, we can hear you, Deepak. Pooja, can you hear Deepak? Yes.
Hi, at this time of stimulation, and doing FET, freeze all, will it affect egg quality in that cycle?
I didn't get your point, Deepak. Could you please elaborate?
Starting antagonist cycle for a patient.
Yeah.
LH as 9.
LH?
LH is 9.
For what? Why we done LH?
Just I thought doing one of I've done LH was high, but still I continued cycle. I done OM pickup, but egg quality not good. Their fertilization failure. To know
So,
egg quality.
So this means, see, I actually don't have, I'll read it. I don't have the exact figure in my mind that what level of LH should be there in an antagonist cycle on day 8 or 9. You have done your thing. I don't have the figure with me. I'll have to read it. What figure is given in the books? In case we find a RCT or a free paper, I will let you know. Definitely I'll put in the group. But remember that LH normally is around 3 to 4 in the body. It maintains at 4, not more than that. Less than 4 to 5, we should start our case, and then don't allow LH to rise. Though the estrogen is rising, we don't allow LH to rise. And how do we do it? We start timely antagonists. Cetronellix has to be started timely. In case we don't start, then LH will start peaking.
Okay.
So in case you have 9 or 10, maybe on the higher side, going by the routine menstrual cycle and my understanding of physiology of induction protocols, I think in that you please start her antagonist 1 or 2 days prior in the next cycle. Suppose starting antagonist on, normally we say we start antagonist on when the follicle size becomes 14 and endometrium becomes 6 or we start antagonist. That's what I do. You start them 1 day prior.
So my question is, should I have not done this cycle being LH high?
I don't have an answer. Really, I don't have an answer. I don't have.
I could have get single fert egg. She was the AMH was 4.5. She's slow growing. Iodine 2-3 IUI. Then that also they were growing very slowly. So I thought of cancelling, but I thought I'm freeze all. I will not. So egg quality will not hamper. Correct. But I any fert egg.
दीपक मैं पढ़ के बताऊं आपको मैं
Yes, sir, yes.
Because it's a very nice question. इसका अभी मेरे पास actually जवाब मेरे में ठीक जवाब नहीं है. मैं आपको पढ़ के आपको बताऊंगा. I'll put in the group. And thank you so much for. In case possible, just would I just note this question? Note this question. I'll do some research on this. What is the right call?
Right. It's very difficult.
Stopping a cycle is always very treacherous at this point of time on day 8 or day 9. But let me read it, and I will revert back to you.
Okay.
Thank you so much, Deepak, for giving me stimulus. Thank you so much.
Thank you.
Yeah, thank you, Dr. Deepak. And we'll let you know in the group. I'm sure you are in the CR group, sir.
Yes, ma'am. Yeah.
We'll revert on this.
Sure.
Thank you. Thank you very much. 10:30. Should we stop?
Yes, if no question left, I think we should end. It's 10:30 and too late. So is there any question left? Please let us know. We have 1 minute more to go. Otherwise,
I wanted to ask, excuse me.
Yes, sure.
Yes, Jaya, ma'am.
Sir, I wanted to ask in this estrogen was in the red, with the red this thing red light, but in cases of thin endometrium where we have already stimulated with letrozole and the endometrium is not growing vascularity zone 2. So in those cycles, can we add estrogen or we shouldn't add?
You have to add. There you have to add. See, what I've told you is that these reds are the ones which are besides our regular practice. Like when we do FET, we add estradiols to all the patients from day 2.
Yes.
That is normal.
Okay.
When we give LPS, we add progesterones. That is all green zones. Sorry, they're all green zones. But people have started adding estrogens in a luteal phase support.
Okay.
That is wrong.
Okay.
So we have to add estrogen when the follicle size goes more than 14 millimeter and endometrium is less than 6 millimeter. There you have to add.
Okay.
So that is a green zone already. See guys, you understand that what practices we have been taught till now, they are all in green zones. Today we spoke about the practices which we are doing, new things which we are adding.
Okay.
They are the amber and red. So routine practice, all IVFs are in green zone already. They are safe. But add-ons, nutraceuticals, adjuvants, adjuncts are the ones which we are discussing today.
Okay. Thank you, sir.
Sir, continuation of this question, if you start estrogen for endometrial thickness to improve endometrial thickness, can we continue? I mean,
you have to continue. You'll have to continue. Can you put in your camera, please? We are now 120 people. We were touching around, I think, 298, and it's so nice to now we can actually look at each other. Normally we go crazy, and I can't see you. I can see Rida also. Hi, Rida. How are you? How are you doing? Good, good, good. Yes, sir. A very nice question you have. So once we start estrogen, we have to continue till 70 days.
Okay.
Once, see, it's something like an LPS. It's a pretty complicated stuff. Luteal phase support, when we had a class, I had given you the lovely world literature by Weissman and a lot of people. They always said that we can stop the luteal phase support that day beta CG comes positive. One. Second was that when the patient has got the heartbeat. Third, we can stop at 7 weeks. Fourth, we can stop at 10 weeks. This is what we are doing all in our country till now. So at all the points we can stop, but we are so scared that we are all going till 70 days. This is what we all are doing. 70 days we are giving the whole luteal phase support, and once we are giving till 70 days, it's obvious that your estrogen, which we have added as a support, and she has become positive, that becomes a part of a endometrial support that should continue till 70 days, because we are actually scared.
Yeah.
That's a world literature we can stop.
That means till 10 weeks. 70 days would mean 10.
Yes, 10 weeks, 70 days we give. 70 injections, 17 vaginal applications, but we are here again I gave a lot of evidence, I collected all the evidence in the luteal phase support lecture. I sent 3-4 articles which says we can stop anytime. We are afraid to stop. So I think I'll ask a few senior people present here, Dr. Geeta, Dr. Sushma, what do they feel about stopping or adding estrogens in case they are there, they can take this question. Anybody who's doing IVF, they can take a call on this. In Pakistan, people giving estradiol tablets only. I don't know what is the indication here. So, anything else we can talk on? She's showing something.
Dr. Ruxana ma'am wanted to ask something. Hi, Dr.
Yes,
Ruxana.
Dr. Ruxana, how are you?
Hello, sir. How are you?
Hi.
Natural herbs, and they have a in ancient times they had a very good like.
We can't hear you, ma'am.
Sir, आवाज आ रही है?
अभी आ रही.
जी मैम.
Indians are very good in natural herbs. I want to ask anything added for the natural herbs to increase the endometrium receptivity for the fresh or the frozen embryo transfer, like herbs.
Herbs, जो herbs होती है ना, herbs, I think the only herb available as in herb are no herbs barring goji seeds. We have goji seeds for the men, and for the women we don't have any herbs per se available. They are we have berry extract, we have got ashwagandha, we have got ashoka rest, we have got falgret, but they are all part of capsules and tablets or some sort of a gel like ghee which they sell by Ayurvedic shops. I don't think any herbs are available in our country, what we write for people. For the men, the only seeds which they can take is fenugreek, as an Ayurvedic fenugreek seeds, and goji berries. But for the women, they got those herbs in packaged forms. These I told you, these 4 work very well. Close your eyes and give them ashoka rest, ashwagandha, and they will give them some berry extracts. They work very well for PCOS also.
Sir, in one of my patients, sir, I am trying frozen embryo transfer since last 1 year, and I have cancelled her for 5 times because her endometrium is not growing more than 5.8 or 6. And I have done every test. I have tried extras, I have tried PRP and everything. What to do next, sir? I am fed up with, but the patient is also fed up with me, and I am also fed up.
You can do for them an hysteroscopy. I think she deserves an hysteroscopy now at this point of time.
Sir, I have done hysteroscopy. She is actually wife of my old staff.
Okay.
I have done hysteroscopy also, but nothing is wrong in that hysteroscopy. I found everything normal, and actually she is having one baby also, which is around 6 years old, and she delivered by LACS. And after that, there is no significant history. They came to me just because they are not having their babies. So they came, and I found that the main cause of infertility was male factor. Male is having oligospermia, oligoteratospermia is there.
Okay.
And I have done ICSI for that.
Okay.
Because they are not able to conceive even after IUI.
Okay.
But now I am having 6-7 embryos, but I am not able to transfer in that patient. How I should proceed in that patient?
Ma'am, I think in such a case, the right thing for you will be try when you have tried everything. One thing you can try for her is giving her Fulgurith. Or you can always start her cycle. You can induce her cycle with tamoxifen. Okay. Tamoxifen works very well, ma'am. Tamoxifen, when everything fails, tamoxifen works. 20 to 40 milligram, that we can talk offline sometime. So 20 to 40 milligram tamoxifen can be given. Tamoxifen is very good for refractory endometriums. And along with that, you add some Ayurvedic medicines. They work very well. This is what I will do. I try for 2 cycles in case it doesn't succeed. Then you take the call whether you want to go in for surrogacy or something. But you must try 1 or 2 cycles with tamoxifen. They can do wonders.
Okay. Thank you, sir.
Have you tried tamoxifen for her?
No, sir. I have never tried tamoxifen.
Try karo. It works. Tamoxifen works in all these refractory cases. Tamoxifen is
tried everything other than tamoxifen.
It works very good.
Even gonadotropics I have tried. I have given gonadotropin just to increase the endogenous level of estrogen. But it is not working. After 5.8, 5.9, there is arrest of endometrium growth.
Refractory. So I think do a color Doppler and put her on tamoxifen. It may work.
Okay, sir. Thank you, sir. Thank you very much.
Thank you. I think we'll end here now. Until somebody has some query, last question we can take and say goodbye to you all.
Okay, sir.
We can see so many friends here. Thank you so much for joining us. We really enjoyed. And I would like to thank Dr. Mandira for being.
Your lecture is like a Sunday feast for us.
Thank you so much.
I was a hostler and we get feast on Sunday.
Okay.
So your lecture is like a Sunday feast for us.
And you give me homework to read. I also reading the whole
It gives homework also.
Thank you, really everyone. Thank you so much. It's really hard to hold for such a long time in Sunday morning. I can understand it is a valuable and precious Sunday we all have. Thank you so much. And your presence gave us a lot of strength and positivity. And thank you so much. I'm just getting messages. Thank you so much for the kindness, for the appreciation and lovely messages. Thank you so much.
Pooja, we must thank Dr. Mandira and tell her to sum it up. She's sitting with us strong.
Yes. Dr. Mandira ma'am is such a nice, I felt like we are friends since she was going to Vaishno Devi. And I'm still waiting for the pictures, ma'am. You haven't sent yet. So ma'am, I really request you to please submit up this CR today and we'll meet in the next CR coming up alternate Sunday. Yes, ma'am.
Thank you very much, sir. Thank you, Dr. Pooja. It was really very, very enlightening. As usual, I must say it, like that is the word, we should use it always. Like whenever we are sitting with you, we learn so much. We get so much like small tricks of the trade and it really helps us. And these curtain raisers are really like though it really takes, as Dr. Pooja said, some time of our Sunday, but it's so much enlightening. I would just close my door. I would say, please do not disturb me now because I am here. So it's a really an amazing experience for all of us, and we learn a lot from each other. Thank you so much, sir, for continuing this, and I hope you will continue it so that we can go on learning from you.
Thank you so much. So guys, take care. Have a nice day. Enjoy yourself. Bye.
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 Sunday.
Namaste. Bye bye.
Yourself. Bye. Bye. Be safe. Be happy.